Good morning, everybody. Thank you very much for coming to this conference. I hope you found it okay. I hope those of you that came last night had a lovely time in London and maybe you weren't involved in any of the demonstrations with the anarchists or anything like that. Put your balaclavas away now. But I'm really pleased that you're all here today, and I'm also delighted by the programme that we've got today. I'm sure you'll agree it's a very full programme, but hopefully it's going to really give us food for thought in terms of the advances in stroke rehabilitation. So my name is Fiona Jones, and I'll be speaking later about my area of research, which is self-management. But before we start, I just wanted to tell you the story of how we got to do this conference. And I was asked to speak about this time last year at a stroke conference that was organised by Medinio. Where do you think the one presentation on rehabilitation was in the programme? Last presentation. And so I dutifully sat through all the presentations and watched this cascade of people gradually leaving, and by the end I actually delivered my presentation to 4 people. So all the doctors had gone and there was 4 therapists left, and the chair, so that was 5. So I was disappointed because I put a lot of work in, and as I'm sure all our speakers have put a lot of work in, but I think that sends a very strong message to us as well, that we've got to work really, really hard with our medical colleagues to put rehabilitation firmly where it should be. Yesterday I received an invitation to speak at another stroke conference, and rehabilitation has made its way to after lunch. So I'm measuring my progress by where I am in the programme. So we have a nice indulgent day today because actually we've got rehabilitation right the way through, and also we're ending with a presentation that I think is going to be the perfect way to end the day. So I think I'm going to get on and introduce our first speaker. The other nice thing about being able to put forward ideas for this conference is that you get to ask the people that you'd like to listen to as well. So a lot of the people on the programme are people that I would really like to listen to if I was sitting at a stroke conference. So I hope you agree with me. First speaker is somebody that I've known for quite a while, Professor Geert Verheyden, who is a Professor of Rehabilitation. He's a physiotherapist by background. He's worked in the UK for some time, but now he's returned to Belgium. You've got the career history and the synopsis of his talk in front of you in the programme, so I don't want to take any more time away from his presentation. But just to say, I'm delighted that Geert is with us today, and I think it will be a very good start to our programme.
Well, good morning, everybody. And thank you very much for the very kind invitation and for the very kind introduction. It's quite early and hopefully no one leaves, so that would be a good thing to start. But I thought of starting with 3 key messages. You know, we're all fresh and it's early morning, so I want to give you 3 key messages right from the start, and afterwards I give my talk. So the first key message is we need to measure our people with stroke, and we have to do this with standardized outcome measures. That's number 1. 2, why we have to do this, because I believe, and hopefully my story will convince you of this, that it's part of evidence-based and good practice. So that's number 2. We need to measure our people with stroke, standardized outcome measures. 2, why? Because it's evidence-based practice and good practice. And 3, this is quite an old one, but I believe it's still a good one. Yes, you can. You can measure. And hopefully I will be able to convince you of this. So this is the outline of my talk. I'll first start with an introduction, and I'll situate if we have a problem, or if there is a problem with using outcome measures, because I think there is. We'll go over some reasons why we not use outcome measures, and I think these reasons will be quite similar maybe for you working in private practice. I then go on telling you why we should use outcome measures. You heard it in the second key point already, but repetition is an important learning theory. So, secondly, I will go through a framework that might help you with deciding what outcome measure you best use with your patient. Thirdly, I will help you with gathering information about finding outcome measures, because that's a frequent problem that I hear with people working in clinical practice. And I work in clinical practice myself because I work half a day a week at our neuro stroke ward, rehabilitation work, so ward with people with stroke. There are two possibilities, I think. One is looking in published literature. The second is looking at online resources. And that's a very useful tool, I believe, where you can find outcome measures and also good information about outcome measures. And finally, I want to end with a clinical example of how we could use outcome measures to our advantage, because that's what we have to try. Good. So first, the introduction. This is quite an old study. There are not that many studies conducted on the use of outcome measures, I believe, but it's presented in the book by Emma Stokes, which was, recently published. And it's a survey of Canadian physiotherapists. I'm a physiotherapist by background, so there will be a slight bias, but I believe there will be something for everyone to take away from this. So it's a survey from Canadian physiotherapists about the use of outcome measures. And as you can see, this is the top 5 of outcome measures that they use on admission and on discharge to a rehabilitation ward. This was very general, not stroke related. And besides the outcome measure, you can see the percentage that people use this. Now, I think there are 2 lessons to take away from this. First, I think the percentages are quite low. If we look at 85% that uses an outcome measure on admission and discharge, and this can be different people, of course, it's not that all the people used all these 5 outcome measures. And if we look at what kind of outcome measures that they use, I don't think they are, the outcome measures that we should really focus on. I mean, some of them might be quite important, but if I look to a standardized scale that will be the focus of my talk today, I see this just on place number 5, the Bird Balance Scale. And of course the others might have an important place in rehabilitation, but hopefully through the talk you will feel the same way as I feel about these outcome measures, that they should not be the primary focus of our practice. So I think it's fair to say that there's no optimum use of outcome measures in clinical practice. And this is from Canada. If I look at my own situation in Belgium, for instance, I definitely see the same things. So these are the reasons, again in the same study, for not using outcome measures. And as I mentioned before, if you work in clinical practice, they will be quite familiar, I think. I don't have the time to use outcome measures. I have to treat patients, so I don't have the time. I don't know a lot of things about outcome measures. They are just not that available. Where do I get these outcome measures? That's also something you frequently hear. They're not really meeting the needs of my patients or my clients, these outcome measures. And there's a lack of professional consensus. When I go to a meeting, I hear something about outcome measures this way, and then I hear something about it the other way. So there's no professional consensus. So why should we use outcome measures? And this is of course related to physical therapy or physiotherapy, but I believe every one of the allied health professions has some core standards. And for physiotherapy, the World Confederation of Physical Therapy has published core standards. And standards, as you can say, tells us that, taking into account a patient's problem, a published, standardized, valid, reliable, and responsive outcome measure is used to evaluate the change in a patient's problem. Right? And then beneath there's some other information which you can read, which is probably relevant as well, but which I'm not going to read. So the use of outcome measures is definitely, I believe, a critical component of evidence-based practice, because standardized outcome measures are not just there, to use and to have a number for your patients, but they can help you with diagnosis. Not diagnosis of a condition, but diagnosis, for instance, whether a patient has a false problem or not. They can help you with prognosis. It can help you with developing a plan of care. It can help you in assessing a patient's progress and evaluating the effectiveness of your intervention. And also showing that to your patient. I think that is very important. This is something I wrote with Anne Ashburn. It's a chapter on stroke, and we presented, a workflow for the physical management of working with people with stroke. And on top, we found it quite important to stress that we need to use standardized outcome measures right from the start, right from the first assessment of a patient. And then you can see all the way down this flow, right up until the end where it says integrating self-management, and we will hear later on from Fiona about this as well. So also looking to the future, and this is something that was raised in Physiotherapy Research International, I think in this issue, that we have to consider improving life after stroke for our patients. That's quite critical. So assessments should start from the first hyperacute phase after stroke. It's essential to document physical therapy interventions, and it's crucial when considering health politics, because in the end we will have to show that the things that we do, that they work. And we will not show this by telling ourselves or our patient that he or she has improved her balance, but we will need to document this with numbers. Okay, so that's the introduction. Secondly, the framework. So how might this work? And this is adapted from a publication in the Journal of Neurological Physical Therapy some years ago. And it starts with when a patient is referred to you, to your practice, or to your rehab ward, or to your acute ward, where you start with an initial list of outcome measures. When you go through the history of the patient, you refine this list of outcome measures. Through your initial observations of the patient, again, you refine this list of outcome measures. Going through the systems review of your patient, all the different systems your patient has, you further refine this list up until the end where you make a final selection. And with regard to this final selection, there are some building blocks that we can consider. And these blocks will be discussed in the slides later on. It's about what do we want to measure, what should be the purpose of this measure, what is the type of measure, what are patient and clinic factors that we need to consider, what are psychometric factors, this is statistics, quite important for standardized outcome measures, and what is the feasibility of our outcome measure that we need to use. So the first thing, what do we want to measure? And of course this is related to the International Classification of Functioning, Disability and Health. And we need to consider here, do we want to measure something at the level of body function structure, or maybe activity, or maybe participation, taking into account environmental and personal factors for our patients. And at different stages after stroke, things will evolve probably towards maybe a different category of the ICF and a different outcome measure. What should be the purpose of the measure? We raised before that outcome measures can have different goals. We can maybe discriminate, we can maybe predict, we can maybe evaluate, and it's important to know that outcome measures can serve all three purposes, but they don't need to. They may only serve one purpose, and it's important to know then what this purpose is with regard to choosing your outcome measure. So an example is, for instance, gait speed measured with the 10-meter walk test. It can discriminate between home and community ambulation. It can predict discharge destination. It can evaluate